El siguiente presentador es el doctor Paul Croarkin, de la Clínica Mayo. Él es un profesor asistente de psiquiatría y psiquiatría de niños y adolescentes. Su trabajo clínico se enfoca en esta población, específicamente con pacientes con trastornos afectivos. Él actualmente recibe fondos de investigación del National Institute of Mental Health y del Brain and Behavior Research Foundation. Así que lo cual le permite hacer bastante investigación, otra vez, como les digo, enfocada en niños y adolescentes, pero no solo con TMS o con estimulación magnética transcraneal, pero también con otros métodos de neuroestimulación. Lo tenemos aquí en el Perú, es también un gran privilegio, gracias a los buenos oficios del doctor Alarcón. Así que, bienvenido, Paul.
Hola, hola amigos. Mi nombre es Pablo Croarkin. Lo siento, hablo poco español. Today, I'm a child psychiatrist from Mayo Clinic, and my research and clinical interest is mood disorders in childhood, adolescence, and young adult, and specifically focused on TMS paradigms and brain imaging to study neurophysiology and to improve therapeutic options as far as RTMS and non-invasive brain stimulation. And I'm proud to share our group's efforts over the last 5 to 10 years in this line of research. A little bit about, have funding from a variety of sources, and in the spirit of full disclosure, I work primarily with the Neuronetics device and the MagStim device, and that's just by virtue of the fact that those are the machines I've had access to over the years, and we now have research funding from Neuronetics for a multi-site RCT that both Dr. George and I are involved in for adolescent depression. So today I hope to give a brief overview of adolescent depression and then talk a little bit about our work with transcranial magnetic stimulation and proton magnetic resonance spectroscopy to study the neurophysiology of early onset mood disorders. And then we'll talk about therapeutic RTMS and adolescent depression, our group's experience thus far, the safety, tolerability, and what we've seen so far in terms of the putative clinical effectiveness, and then biomarker development, and then a very few words about transcranial direct current stimulation in the context of child and adolescent depression. And one of the qualifying statements is that much of this work is preliminary, so there's much to be skeptical about, and we have to take a very measured approach to interpreting these data. But I would argue there's lots to be excited about as well. So I think many of you that work in psychiatry are probably well versed in this already, that depression is a significant problem in adolescence, impacting millions of children and adolescents worldwide annually. And it's striking that if you look at studies on functional impairment in comparison to things like cardiac diseases and pulmonary diseases, it actually often trumps those diseases in terms of what it does to children and family. It's a leading cause of economic burden as well, and disease burden. So we had a wonderful introduction to DSM-5, and I think, again, coming from a child psychiatry perspective, it's wonderful that this, in my view, this iteration of DSM is a quantum leap in that we actually recognize the neurodevelopmental aspects of psychiatric disorders, that these, by and large, are not illnesses that present de novo in adulthood. And we've also seen more of a development in terms of the book, how it's organized, and it takes into account the neurodevelopmental impact of these classification systems, which if you're familiar with the older iterations, it was basically the child and adolescent chapter looked much like an afterthought. We just kind of will stick this in the book, and that's there because we have to put it there. Along those lines, I think this is very important. A major thesis that I'd like to leave you with today is that in my view, child and adolescent depression and other psychiatric disorders are highly heterogeneous and fluid compared to adult. We don't always do this for a variety of pragmatic and ethical constraints. We probably need to get beyond translating adult research protocols to children, and we need to think more thoughtfully about neurodevelopment and the potential differences that these patients or research participants will have. We need all the help we can get, all the hands on the elephant as far as studying biomarkers and neurophysiology, and that's illustrated. It's kind of small to see, but that's a collection of effect sizes from antidepressant trials in adolescents, and you can see that our usually the best we can hope for medications are, breaking the 0.5 effect size barrier. Sometimes the placebo actually beats the active agent in these trials. Similar findings in cognitive behavioral therapy when they look at this as far as a collection of CBT or psychotherapeutic trials. And this, I think, speaks, there are a lot of difficulties around designing these trials in children, but I think it speaks to what I'm talking about in terms of the heterogeneity of what we're dealing with when we say a major depressive disorder in a developing youth. So how I've gotten interested in this is studying the Gaba and glutamate neurotransmitter systems. These are, as you know, major neurotransmitter systems, kind of the yin and yang of the central nervous system. And it's almost, I've heard very senior, esteemed researchers that have worked in this area that have joked that it's almost, these chemicals are surely implicated in some respect. It would be a bit like studying the oxygen and CO2 theory of asthma, for instance. But as you likely know, glutamate is a primary excitatory transmitter and GABA is an inhibitory neurotransmitter. Both have very interesting developmental courses through childhood in that their functions have a host of changes that we really arguably poorly understand, as well as changes in receptor compositions as well. And again, we've focused recently more on glutamate in terms of our MRS studies and TMS studies that I'll share with you a bit. Glutamate is metabolically a precursor of GABA. And you'll note, if you can see over in the green on the picture, the astrocyte, glutamate is broken down into glutamine. This is very important. Detoxifies ammonia. This cycle probably takes up 80% of the brain's glucose oxidation. So it doesn't take a biochemist to realize that this is probably pretty important or an important regulatory step. Again, glutamate has a host of roles in mood regulation, memory, synaptic plasticity, and there's ample evidence that antidepressants may reduce the presynaptic release of glutamate. So if you were going to study this in children and adolescents, you really have limited options. You can't do brain biopsies. You could do CSF studies, but spinal taps, that would be very difficult. Another option would be SPEC and PET scans, which a group in Japan is doing some very fascinating dimensional work in anorexia and ADHD along these lines. But the problem here is it's very difficult to personally and ethically, and for institutional boards, regulatory boards, to justify the use of radioactive tracers in healthy children. So scientifically, that's a problem at the end of the day. So what we've focused on in this regard recently is the idea of using transcranial magnetic stimulation, single and paired pulse paradigms. Very different than what you've heard about so far from my colleagues. This is for the express purpose of studying neurophysiology rather than a therapeutic intervention. And the idea of looking in tandem at proton magnetic resonance spectroscopy. So this is take a structural MRI and you can select some voxels, areas of interest in the brain, and look at the chemical composition. You can look at chemicals like glutamate, glutamine, and a chemical called N-acetylspartate, which is the big peak you'll see in the red there on the left. For the paired pulse, single and paired pulse paradigms, what we do is we hook up the participants to EMG, surface EMG, and we locate the portion on the motor cortex that stimulates a motor evoked potential, a thumb twitch, and we measure changes in the amplitude of that motor evoked potential. We determine what's called a motor threshold, as we do for clinical treatments, and then a conditioning stimulus and a test stimulus. Conditioning is a subthreshold stimuli, test is super threshold. And we vary the distance between those two TMS pulses to create what are called inhibitory or facilitative paradigms. So if they're very close together, you can see the two bumps on the TMS strip, their EMG strip, they're inhibitory, meaning 5 milliseconds or less. If we move them out a little bit farther, we get what's called a facilitative intracortical facilitation paradigm, which means the MEP is bigger, larger. We think that these indices are indirect measures of GABA A, GABA B, and NMDA glutamatergic receptor activity. So the ICF measure is a measure of NMDA glutamate receptor activity. What's called short interval cortical inhibition is a measure of GABA A. One other single pulse paradigm that involves the patient or the participant actually exerting 20% their maximal force with that muscle of interest. And you can see we administer a suprathreshold TMS pulse. You can see there's that flat line quiet period on the EMG strip. That is called the cortical silent period. And we think it's not without controversy, but we think this is an index of GABA B mediated neurotransmission. So very shorter CSP would mean that there are deficits or difficulties with this, this receptor.
Excuse me.
Yeah.
You can use this pointer if you want.
Oh, great. Thank you. Gracias. So these paradigms have actually been studied frequently in developing children, and this is a fairly old slide, but you can see up to 2001, approximately 2,000 research participants that are under the age of 18 had been exposed to this. So they're relatively safe, well-studied, tolerable protocols. Sometimes they've been studied in toddlers or infants, for example. And there have been looks at assessing adverse events and tolerability on a larger scale. So this is a very, I think, a very cute study from Dr. Garvey, who's now at NIMH, who looked at some children with ADHD who had gone through this protocol. You can see there were almost 40, and did a tolerability measure and had a very, very pragmatic, clinically oriented. So you can see that TMS was a little bit better than a long car ride, but not as good as watching television. So getting back to the what can we do with these paradigms I'm talking about. So there have been two adult studies, one by a group in Germany and another by a group, a Canadian group, that have looked at these what are called measures again of cortical inhibition and facilitation, single and paired pulse TMS measures. And they both of the studies have demonstrated that adults with major depressive disorder have deficits in this cortical silent period measure of GABA B mediated neurotransmission. Treatment-resistant depression, those participants demonstrated a deficit in short interval cortical inhibition. So what our group sought to do a few years ago with the help of an RSAD grant was to look at this. We thought we'd try to replicate this finding in developing children and adolescents with depression. So we recruited 24 youth with depression and 22 healthy controls. These were subject participants that fortuitously were going to go into another study with an SSRI, fluoxetine in particular, and CBT. This is a CDRS is kind of like in child and adolescent psychiatry, that's our Hamilton. A 40 is a standard cut point for a major depressive episode for studies. This is in the moderate range. So fairly, they were clinically and functionally kids that were ill enough that they wanted to be on a medicine for depression, their family thought they needed it, and their treating clinician did as well. So interesting, what we found was that the findings were almost completely opposite as what's been published in adults. The GABA B mediated TMS paradigms were no different among controls and depressed patients. We did, however, find a fairly consistent elevation in the intracortical facilitation measures in the depressed youth, reaching significance with 2 of our measures and trending with the other. So this is a little bit interesting to reconcile in that one theory, highly speculative, is that perhaps adolescent depression is a hyperglutamatergic or a state with active NMDA activity resulting in excitotoxicity that damages GABAergic interneurons later in life, resulting in these findings we find. So we've also, in an exploratory fashion, Dr. Lewis, a postdoc that works with us, has looked at the idea that can we look for correlates of symptom severity, like we heard about in our introduction today, that it would be very useful if we could find neurophysiologic measures that index and correlate symptomatic findings. And what we found with this recent study is that the cortical silent period measures actually had an inverse correlation with quick inventory for depressive symptoms measures. So meaning that the higher the depression severity, the shorter the cortical silent period, and again, suggesting GABA-B mediated deficits. And we hope, Dr. Lewis is very interested in the idea of developing a platform of these electrophysiologic measures to index suicidality as well. So hopefully we'll have some more data on that soon. We've also looked at another measure, long interval cortical inhibition, and this is a suprathreshold TMS pulse, conditioning pulse, and test pulse, leading to inhibition in normal physiology. And we were, in this case, we looked at 16 depressed youth that were, again, going to be treated with fluoxetine. We had baseline measures of LICI, and then we watched to see what they would, if they were responders or non-responders. And this is a scatter plot that shows, in general, the responders had lower LICI, which is confusing. Lower LICI actually indicates better inhibition. So the responders had, in almost all cases, it reached significance. Lower inhibitory functioning, lower numbers, but actually better inhibition than the non-responders. And this is, again, a very small sample size, so we have to be skeptical about it. But it's hopefully will be of use in the future to replicate. And again, it's kind of difficult to wrap your brain around why would this matter? GABA, what is GABA-B? This is a GABA-B measure, once again. What does that have to do with fluoxetine? Well, there's ample evidence that there's serotonergic, GABAergic crosstalk. And one of the receptors involved is 5-HT2C. And interestingly enough, fluoxetine is unique among SSRIs in that it actually antagonizes that receptor. The clinical significance of that is still debated, whether it means anything or not. So a little quick primer on MR spectroscopy. I think many of you are well versed in this already, but this again we can set a rather large voxel, usually 3 by 3 by 3, and look at a chemical spectra in that area. And this large peak is NAA, a measure of neuronal integrity. The chemicals that I would argue are more interesting are right here, GABA, glutamate, and glutamine, and they're technically much more difficult to acquire and analyze, unfortunately. But this technique does have its limitations as well. You need a chemical that's in a millimolar range that's freely mobile, so it's not on a membrane or in an organelle, so that causes some other controversy. But arguably, we know the brain is a high energy utilizer, so it's probably a good tool for this area of inquiry. So again, just a little bit about what's been done with NAA. We think that this is a measure of neuronal viability. It's been looked at, like, for example, things in like stroke, traumatic brain injury, and these measures, we think lower NAA indicates that the neurons are unhealthy. Adult studies have demonstrated that it's reduced in general in bipolar disorder. The findings have been somewhat inconsistent in unipolar depression. So to give you an idea, this is one early study by Dr. Mark Fry, that looked at the idea of correlating illness burden with NAA, and it turned out that manic patients with a higher illness burden assessed by number of hospitalizations actually had lower NAA levels as compared to their other patients. We've recently also looked at this in terms of lamotrigine treatment for bipolar depression using a little bit more of a little more sophisticated methodology involved at 2D spectroscopy. We were able to look at a group of 15 bipolar depressed patients, again starting lamotrigine, compared to nine healthy controls. And what we demonstrated with this technology is that at baseline, the bipolar depressed patients had lower NAA, lower total NAA, and after 12 weeks of lamotrigine therapy, this actually corrected, and so that they were indistinguishable from control patients. This was a very small sample size, so there were unfortunately no correlates with mood improvement or response, so it's strictly a brain-based finding. So a little bit about, again, glutamate is as you know, an abundant neurometabolite, but it's very, very difficult to distinguish from glutamine. In the older studies, if you read, you'll look at there's often a kind of a soup called GLX, and that's in general, that's in those studies we clump together glutamate, glutamine, GABA, and probably glutathione as well. But in general, in the adult literature, GLX and glutamate have been reduced in unipolar depression and elevated in bipolar disorder, sometimes regardless of disease state. Glutamine is even more difficult to resolve because it's much less concentrated than glutamate, and the two often confound each other due to their structure. But again, it would be, I think, ideal to study this in a more detailed fashion. GABA is also equally difficult to resolve. What's been done, one I think arguably clever approach is to look at ratios. So Doss Unger and his group have looked at the glutamine to glutamate ratio. So you actually, rather than looking at these two, you resolve both of these metabolites, look at them in tandem with the idea that this might be a more sensitive marker of glutamate neurochemistry or perhaps glutamate turnover. And this is one finding where they looked at an early change with riluzole, a glutamatergic agent, again in patients with bipolar depression. These are adults again. So as far as what's been, I'm going to try to go back here, what's been done in adolescents and children and adolescents, it's fairly limited work as far as MRS. Vilma Gaba has a nice study that's demonstrated decreased GABA in adolescents with depression. Probably this was driven by anhedonic subjects, interestingly enough. There have been some discrepancies, but by and large it's similar to the adult findings in that we think that depressed adolescents probably have decreased glutamate, decreased GLX, whereas bipolar subjects may have an increase. So sorry, I'm having trouble with this here. What we're working on currently, and maybe in the future, hopefully you'll read about it, or we'll have another conference and talk about it some more. We're going to look at these TMS measures and MRS measures concurrently. Unfortunately, not interleaved yet. We hope to do that someday, but same day measures of these four groups. Group with healthy control, group that's unmedicated with moderate to severe MDD, a group that's responded to an SSRI, and then a treatment-resistant group. We're halfway there. We hope to get 100 participants for this, and we're to 50 right now, so hopefully stay tuned. We'll have more to report on soon. So change gears a little bit and talk about therapeutic non-invasive brain stimulation, and by that I mean RTMS. We'll talk about TDCS very briefly with the idea of optimizing these for adolescent major depressive disorder. And our group at Mayo Clinic now, we've treated in research protocols only now 24 youth in 2 open label trials and a randomized controlled trial that's now on hold, and we again we're in the U.S. we're launching a multi-site study with Neuronetics to look at hopefully 100 youth throughout the study, with the idea that hopefully this will provide data to help with the FDA registration process. So this will be available as a safe approved method of treatment for adolescents. So there was a very important article in Brain Stimulation in 2015 that looked at a very exhaustive review of just looking at the safety of both of these techniques in youth, RTMS and TDCS. And they were able to pull 48 studies with over 500 subjects altogether, ranging from the age 2 to 17. In general, the indications tend to be ADHD, autism, depression, epilepsy, and Tourette's and stroke. In general, the side effects were fairly mild and transient. Headache with TMS, scalp discomfort, some fatigue and twitching, TCS, tingling. But again, we need to be cautious in that often if you dig down and look at these, there's an excellent review, but if just by virtue of the limitation of the studies, there's very little in the way of long-term data and longitudinal studies. I can tell you anecdotally in my experience that the RTMS, the big complaint I get is that it's often just boring. Doc, I don't want to sit still. I don't want to put my iPhone down, those kind of things. Here's what's been published as far as adolescent RTMS trial. Pretty meager numbers. In general, these are open label studies. We have one more that'll be published soon that's 10 subjects. And this one, I would draw your attention to this one. This is a very interesting study in Israel where if you read the article, they were actually very ill patients with, some of them had concurrent substance abuse problems and a history of trauma as well. And they had pretty good results with a fairly meager dosing strategy. Same would draw your attention to the Yang case series as well, in that what was interesting to me is they treated for 3 weeks and had fairly good findings. This clinic, the first one in 2011, and at this point we treated 8 open label. We started with kind of violating that idea that I left you with at the beginning. We started with adult parameters that are used in the U.S. 10 hertz, 120% motor threshold, 75 trains, and then 30 sessions for their treatment course. So in general, our methodology, we've until recently treated 13 to 18 in the studies. We're going up in age now by virtue of the fact that the FDA actually, interestingly enough, considers for devices, they extend the definition of adolescent up to 21. We use a structured interview to determine our diagnosis, and we've excluded substance abuse, things like autism spectrum disorders, but have had patients with comorbid persistent depressive disorder, anxiety, and ADHD. The CDRS has been our primary outcome measure, and we've used the adult antidepressant treatment history form to index their refractoriness to treatment. And we do in the past, we've done weekly measures of the Columbia scale for suicidality and have looked at some neurocognitive measures as well. So these are just the overview over the 2 open label studies. First one had 8. Second one had 10. We used the 5 centimeter rule for localization. So if you're not familiar with TMS, we had a great introduction to this already, but I'll just kind of reiterate that to find the location where you put the coil for treatment, what we think is the dorsolateral prefrontal cortex. So we find the area on the motor cortex that provides a maximal, we call it the hot spot, the maximal, again, thumb twitch, and then move it 5 centimeters or sometimes 5.5 centimeters anterior. Very pragmatic, useful approach, but the problem is, it's been argued probably a third of the time or more we're missing the location where we think we are. So pretty important. We'd like, if we're stimulating the brain, we'd like to be where we think we are. For this second study, we were able to do that. We took measures on a scalp cap. We measured the location that would have been the 5 centimeter rule, and then looked at a beam, what's called the beam F3 method that was invented and perfected in Dr. George's lab, which looks at an EEG placement based on 3 very easy scalp measurements. And then we had kind of a homegrown Mayo Clinic technique for MRI-guided localization with the help of stealth technology and a neuroradiologist who would review each of these and give his best estimation of what he thought the dorsolateral prefrontal cortex was in a systematic fashion. So this is kind of slides that talk about what I just went through, that we marked our our MRI guided location, our F3, and our 5 centimeter location with this, using again these 3 different. We actually treated with the MRI guided location in this second open label trial. And we tried to, again, this is, there's been another very interesting brain stimulation paper this past year that Jonathan Downer's group looked at 100 adult subjects and did a similar, again, much more robust study where they compared the F3 measure with an MRI navigated approach. And the finding of that paper was they were pretty close. So this F3 method approximated what you would get with an MRI neuronavigated approach. So we've looked, again, it's 10 subjects and smaller, but it's a start. And we looked at the F3 method and the 5 centimeter rule, and then these colored stars and triangles are the neuronavigated approach. And you can see, if you measure, these are Euclidean distances, so straight line distances with the help of stealth technology from where these 2 locations are. They were statistically significantly different, the F3 and the 5 centimeter approach, and you can arguably, crudely, you can see that if you were going to just eyeball it, the F3 approach probably gives you better results for adolescents as well. Much more to study and think on, though. Again, it's a small sample size. In general, for the first trial, these adolescents did well. 86% of it actually said they preferred this treatment to a medication. We were quite worried about headache and pain to begin with. We have some data that we haven't published yet that suggested that their somatic symptoms and headaches improved over time across both of these trials. The second trial, we had 3 dropouts out of 10. So one was due to scalp discomfort. One was a perceived lack of efficacy on the patient's point of view, and she was, I remember her, she was actually very nervous and wanted to get back to school, and interestingly enough, her treating clinicians and family thought that her depression had improved. And the third was a very ill young man who went on, he had suicidal ideation and was hospitalized, and then he unfortunately went on and actually failed ECT after this as well. The majority of the families and patients would repeat the trial if necessary, and the second trial we actually titrated the motor threshold, which appeared to help with tolerability, and again anecdotally. So this is again, this is open label, but this is how this gives you an idea of the changes in depressive symptomatology. So we saw comparing patients to themselves, we saw changes pretty early on after 10 treatments. And again, as a child psychiatrist, what's most exciting to me is this, in that at 6-month follow-up, even in an open label study, it's pretty unique to see this, that they were either a little bit better or had maintained their response, which I think is a hopeful thing to think about in the future. Same general trend with the CGI. Second study, similar results, and again, note that at 30 treatments, we were able to get follow-up clinical data at 6 months, and they were improved. And a lot of open-label pharmacologic studies I've seen I don't think could posit that result. A little bit about the neurocognitive effects of RTMS and hopefully the promise. I think this is very important ethically that we look at this for safety, but it's also, we're pondering the idea that this might, at the end of the day, might be a better endpoint and target for future studies. There's robust adult data that suggests that this actually may improve adult neurocognitive functioning in patients with MDD. So we, across the studies I've just run through with you, we collected a children's auditory verbal learning task and the Dellis-Kaplan executive functioning trail making test, more just for safety. It was something that these trials were regulated by the FDA, so we had to demonstrate that we were carefully collecting safety data. And this is, again, this is encouraging. Across these 2 trials, there were no, the lighter blue is the post neurocognitive measures. There were no decrements in these findings. Actually, in one case, the intermediate memory improved a little bit, and you have to be, again, you have to lay a skeptical eye on that, in that there are things to account for, such as practice effects, so maybe that they just got better at doing the tests. Similar findings if you look at treatment completers only. Immediate memory improved a bit, and there were no decrements otherwise. Similar, no statistically significant findings with the Dellis-Kaplan Executive Functioning Scale, but again, it's reassuring that there were no decreases in their functioning from a neuropsychologic point of view. Same with completers. So again, the idea, I think it's very, very important with youth. I've thought a lot about the idea it would be wonderful to have a biomarker. You know, I can see in the future, hopefully I'll have a family in my office and we'll be able to do some kind of a neurophysiologic test that will give mom and dad and the teenager an idea of their chance for success. Because this is, for a teenager, depression is a very, very impairing, morbid condition, as you know, but this is a fairly big time investment and in some cases economic investment for families. So it would be ideal if we could actually take a baseline measure and give families an idea of what their chances for success are with our current dosing strategies, or better yet, harder studies to do, or better yet, use biologic findings for dose finding studies to help guide our treatments. So we're looking at the glutamatergic neurotransmission system in general again, and this has been done with one group in Germany looked at this many years ago, the idea that in a fairly small sample of adults with depression, lower cortical glutamate levels were predictive of response to RTMS. The study I mentioned earlier from a group in Calgary, Yang, again, it was a small case series, but they demonstrated a similar finding with adolescents, that the youth that had lower cortical glutamate levels as assessed with MRS tended to respond and do better than those that did not. So with this second study that I just mentioned, this second open label 10-patient study, we were able to collect some MRS data. We looked at the anterior cingulate cortex and the dorsolateral prefrontal cortex. We looked at these measures before any RTMS treatments at baseline, and then immediately after, either after they dropped out or after they stopped their RTMS treatments, and then did the 6-month follow-up again. So we were able to looked at 2 different brain regions and 2 different MRS sequences. So if you get some spectroscopists together, they can argue all day about the best way to pulse the MRI to get the glutamate measure. So we did 2 different approaches, what's called a TE80 press technique, and then a 2DJ measure that we think gives an optimized measure of glutamate. And again, this just shows you, this is what the glutamate peak looks like when it's resolved, and this is the glutamine as well. We looked at this glutamine to glutamate ratio once again in these 2 brain regions with these 2 different techniques. And interestingly, again, small sample size, need to be skeptical, but interestingly, they trend upward, and it reached significance in the anterior cingulate cortex with this ACC measure, with the TE80 measure. Interestingly enough, there was actually an inverse, also a correlation with changes in the CDRS, which reached significance in the 2DJ measure. So as the depressive symptoms went down, this glu measure increased. So we hope to pursue this in a larger sample size in the future. Wanted to say just a few words about transcranial direct current stimulation. And is anybody familiar with this already, doing this kind of work in the audience? Anybody? Okay, we've got a couple experts in the room. With depression in general, it's probably a very, very different treatment than RTMS, but it involves using electrodes, and there's an anode and a cathode. An anode actually depolarizes neurons, changes the resting membrane potential, where the cathode hyperpolarizes the neurons. And there have been some very interesting studies in depression. There's a little bit of controversy depending on which paper you read. A recent meta-analysis that looked at seven studies, approximately 267 patients, said that there was about a 0.37 effect size. And a lot of the interesting adult work has actually been done in Brazil by Andre Bernuni. Bring this up because this may be some ways a little bit more economical. A question I've always had from senior colleagues with RTMS and youth is, well, can you get one of these? Can you put one of these machines in a school? And that would be extremely challenging. But this TDCS, in some respects, might be a little bit more easy to disseminate, could be a little bit more inexpensive. And my hope is that with child and adolescent work, we will be able to do it in a more measured, thoughtful kind of fashion, and that we can do single session studies in a fairly inexpensive fashion. This has been looked at in youth already. I think there are, last count, there were eight papers that have looked at areas like autism, ADHD, early onset schizophrenia, interestingly enough. But no studies that I'm aware of specifically that have looked at adolescent bipolar disorder, depression, or other mood disorders. So we hope to stay tuned at Mayo Clinic. We hope to change that in the future and pursue some of these research studies with this device as well. Other slide was a shameless plug for there's a textbook coming out if you're interested and you're going to perhaps pursue training in child psychiatry, you want to learn more about brain stimulation. There's a textbook coming out later this May that will cover a lot of these areas in details. I want to thank collaborators at home and again Dr. Kabar for inviting me to this very fascinating symposium. And I think I can field questions, and I think Dr. George and I are going to dance a little bit and hook up his laptop whenever he's ready.